Thank you very much, Sri Lanka Society of Nephrology, for inviting me. And I'm really pleased to be back here in front of you all to talk about approach to hemodialysis related emergencies in children. So my objectives for this talk is going to be case histories on hemodialysis related emergencies. I'm going to explain about how to use structured communication tools in hemodialysis related emergencies and what's the role of human factors in resuscitation during hemodialysis and human factors training. I'll be mainly focusing on the third objective because that's mainly overlooked. So if you see this picture, one fine foggy day, I took this after my on-call, just came out of the hospital. And why is this relevant here? I was waiting for about 10 minutes to capture this. And it's relevant to the human factors we are dealing in day-to-day emergencies. It could be any scenario. You need to think about a situational awareness. So if you see, you can't see forward, it's foggy, but you know there is a team leader, like standing tall, like a South Bank lion. And there is going to be a group of team members going to make a task. On the other side, they're doing a task. And here, the traffic light is showing you don't know what's going to happen next. So you're waiting here. It could be you need to stop or you need to anticipate something, but you're not sure what you're going to do. And there is one person rushing to get some help. You can think like that. So it's really important to think about human factors in emergencies, which I'm going to elaborate later on my talk. We'll talk about the first case scenario. A 12-year-old boy with end-stage kidney disease was found to be turning into dusky color during the hemodialysis session. His saturation started to drop to about 85%, and he was started on 100% oxygen via face mask. And a few minutes later, he started to become pale. How are we going to deal with this situation? It's a bit scary during the dialysis. This is not like we all trained in APLS to deal with the emergencies. But when a child is connected to the machine, the hemodialysis machine, how are we going to deal with this? A critical judgment of a decision, whether you need to stop the dialysis, how you're going to wash back, or you're going to discard the blood. What is this? So if we know what are we dealing with and how are we going to approach this scenario, it would be really interesting to save the life because it's a real-time emergency. And interestingly, when we did the blood gas, we have seen the methemoglobin level of this child's blood gas is 21%, which is very high. So we know we are dealing with methemoglobinemia. And one of the registrars involved in this, called the consultants, and all the professionals are rushed to the scene. And 5 minutes later, another 7-year-old girl sitting next to him started to turn blue. Now, 5 children were having the hemodialysis session. We had to terminate everybody, like emergency termination of hemodialysis. We can't wash the blood back because we are thinking of methemoglobin, high methemoglobin levels in the blood gases. So one-to-one care, monitoring, and pharmacists and anesthetists, everyone is on the scene to deal with this situation. They've started to have hemolysis and their bilirubin is going up. We had to choose, as per the criteria, a couple of children had to receive methylene blue as a treatment of this, as an antidote of this, and one child needed to go to PICU as well. So this is an ongoing issue, and we had to close our hemodialysis unit for some time, and then we had to, transfer the people for the regular dialysis for the other centers. It's really interesting if you know how to approach these kind of scenarios. If we have a structured approach, we can kind of make arrangements to deal with it. So this is methemoglobinemia. We had to stop the dialysis emergency, termination, and clamp the blood lines. Do not return the blood. So in any patients who presents with cyanosis or low saturation out of keeping with their clinical states and which does not improve with supplemental oxygen, we need to think about this. So this is the guidance of, the symptoms could vary from unlikely symptoms in less than 10% of methemoglobin to, if it's more than 70%, could lead to death even. We'll move to the second scenario. 8-year-old boy presented with an acute kidney injury, and he was anuric for about 8 hours. The pre-hemodialysis urea was about 45 millimoles per liter, creatinine was 650, potassium was high, blood pressure was high. He was started on his first hemo session. The initial HT was planned for about 2 hours with an ultrafiltrate goal of 500 mils. He developed seizures after about 90 minutes of hemodialysis. So what are our thoughts? What are we dealing with? A child on the ward having seizure is different from a child having seizure whilst dialysis. So what measures would have prevented this event? Those kind of things we need to think about in this kind of clinical scenario. So we know any blood urea more than 40 millimoles per liter, there's a risk in the first hemodialysis session we could be causing dialysis disequilibrium syndrome because of the sudden osmotic pressure changes during the hemodialysis. Children develop this more often than adults, and brain edema causes the consciousness changes and convulsions. It's always, helpful to shorten the dialysis. That's why we give only 1 or 2 hours maximum of the first hemodialysis session. And as a thumb of rule, we can't reduce the urea more than 40% in a dialysis session to prevent the development of osmotic gradient concentration between CSF urea and the serum urea. So we practice giving 1 gram per kilogram of mannitol with 3/4 of its prescribed volume during the first hour of dialysis, and the remaining quarter will be going in the second hour. The aim of the treatment would be to focus on reducing the intracranial pressure, and the further treatment and management would be depending on the clinical state, and we'll be discussing with the critical care team to monitor in the HTU also. So there's a third scenario, 9-year-old girl with end-stage renal failure on regular hemodialysis. During the session, found to be apneic all of a sudden after 2 hours of hemodialysis. Her dry weight is about 22 kilos and pre-dialysis weight was 24.5. Hemodialysis prescription was about 1.3 liters over 4 hours. Blood pressure at the time of occurrence was low, no signs of life, and having asystole. Quite scary, isn't it? How do we handle this situation? Again, APLS. So we know how we approach asystole. So the working diagnosis would be asystole due to hypovolemia. So the initial action would be, we need to terminate the HT and rapid return of the blood. And we need to reassess 100% oxygen, simultaneous airway opening maneuvers, bag and mask ventilation. They've done measures to elevate the leg end, assessing the circulation, no pulse, CPR commenced. Again, reassess. Adrenaline given, sinus rhythm restored, started to breathe. So measures to do and monitor to prevent this event, appropriate ultrafiltrate rate, and if we can do from our hemodialysis machines to do the BVM monitoring, blood volume monitoring during the hemodialysis to predict hypovolemia. And then we can say this child is going to collapse if we go on removing the ultrafiltrate like this. And the careful assessment of dry weights during our routine dialysis reviews. So hypotension is common during hemodialysis because of, it could be excessive ultrafiltration, too fast ultrafiltration rates, improperly low sodium concentrate in the dialysate, and use of antihypertensive medications, which we can't revert back. Bioincompatibility of the dialyzer membrane. We need to manage by stopping the ultrafiltration, putting the child in this position, Trendelenburg position, and injecting normal saline bolus depending on the clinical scenarios to restore the volume status. This is our local guidance in Evelina London Children's Hospital. If you see the graphs, we could see the ultrafiltrate rates, if that is going about 10 mils per kilo per hour, you are going to cause myocardial stunning. And then the cardiovascular and all-cause mortality is increasing after that. So no more than 5% of dry weight should be removed per session. That's our local guidance. No more than 10 mils per kilo per hour of fluid removal, and no more than 5 hours. So if the child is needing more than 5 hours, we are keeping in ward and assessing and giving another session later. So what's the evidence? Again, the same thing. An ultrafiltrate rate of more than 13 mils per kilo per hour is going to cause myocardial stunning with likely effects on other organs as well, gut and brain. Higher ultrafiltrate rates are associated with greater cardiovascular and all-cause mortality. And this is the non-shockable rhythm pathway we all know. I'm not going to go into detail. Fourth scenario, 13-year-old girl with end-stage renal failure on hemodialysis received her first dose of vancomycin for a suspected vascular access-related infection. 5 minutes later, she was complaining of itchy rash all over the trunk and started to have wheeze and bronchospasm, which is a common kind of an anaphylaxis scenario we encounter. Hypotension, tachycardia, and how are we going to handle this? So we know this could be any form of a reaction, any form of anaphylaxis. We have to blame the vancomycin. So we need to follow the anaphylaxis algorithm as per APLS. So how are we going to formulate, or do we have any approach? We don't have anything as such. So approach to hemodialysis emergencies is always we need to anticipate. Someone could ask, how can we anticipate emergencies? But if you anticipate, if you think about a particular child, if you think about this is my hemodialysis prescription and I'm going to deal with this, there are always possibilities to anticipate emergencies. And we need to be ensuring, asking for help, analyze and assess, and we need to act to stabilize. So if we think of anticipating, there could be several risk factors, isn't it? So if the urea is more than 40, the risk of dialysis dysequilibrium syndrome. And if you're reviewing a child frequently, the dialysis nurse in charge would tell us, this child is having regular interdialytic hypotension. So there's always a possibility of this session is also going to have low blood pressure. This child is always coming with high fluid overload, with high blood pressure. So those are risk factors. The child always, anytime, could throw a seizure in front of us. And this child is having previous various allergies and the risk of anaphylaxis. I'm going to give a new medication. So I'm always be aware of this. So an ounce of prevention is worth a pound of cure. So always we are anticipating for emergencies. How can we ensure we are well prepared? So we always do pre-hemodialysis huddles with all the nursing colleagues involved in this and one of the doctor in charge. So reviewing the previous trigger tools, which we have our local policies, and any significant previous events, following the protocols to avoid excess ultrafiltration, checking the emergency trolleys at a frequent interval to make sure we have everything in place to deal with the emergencies, and train our staff to detect the warning signs early and do the measures appropriately whilst calling for help. Example, we can use the blood volume monitoring, as we said, and regular APLS training for our staff dealing with these hemodialysis. And we could display the APLS algorithms in the hemodialysis unit with frequent teaching and training and the flow chart in a simulated kind of an environment. And obviously, we need to involve the parents as well, because if an anuric child is coming repeatedly with a fluid overload, and parents need to be on board and they need to look at the signs at home as well and to update the hemodialysis team appropriately. So this is another pilot study done by Evelina last year. So developing a trigger tool to monitor adverse events during hemodialysis in children, which was a pilot project knowing about several triggers during the hemodialysis and categorizing them into 6 domains, A to F, and dealing like no harm to significant contribution to the patients like death. And then how could they tabulate from a 8 weeks kind of a period followed by another 8-week period of how many triggers we have detected. So this involves more of a training and detecting the things early. And they have found out the harm rate per session was significantly reduced. And there was a significant difference between the proportion of triggers across the various domains of this trigger tool. So this is a sample of how we tend to review our hemodialysis, like monthly reviews. So if someone is presenting us, this month we have about 12 triggers. These are the triggers. And then we'll be dealing with that and we'll try to prevent those triggers in the next review. That is helping us in order to prevent, and we could find new triggers in the next time, but we are dealing with that. So this is another useful blood volume monitoring curves during our machines. Like we can't see those things. If you see the green kind of curve, that is showing you are removing the fluid more than the refill rates. It should match. You're removing the ultrafiltrate and it should match the refill rates. If you see the first one, if the child is fluid overloaded, the curve won't budge. It's like a plateaued. But ideal would be the adequate UF, the blue curve. And if that's a yellow kind of curve, they need to be alarmed and we need to have a measurement to, like, we need to pause or reduce the ultrafiltrate rate, which is really helpful in preventing hypotension or leading to collapse. And the second part is we are not alone. We need to ask for help. We need to analyze and assess. So if we see the clinical picture at that situation, whoever dealing with that child, whoever the first contact, always need to start ABC approach to assess the child as per the APLS. And we need to ask the question to ourselves, what are the hemodialysis machine settings happening here? And what's the hemodialysis prescription? And how long into the treatment this particular event has occurred? And can I work out what I'm dealing with? Always, like this all, we need to think in fraction of seconds at a spinal level. That's why all this simulated environment is really needed us with frequent teaching and training. What are the vitals and what's the trend of parameters? Do I need to summarize what to say when I'm calling for help? That there comes a structured communication tools, which I'm going to talk in about a minute. And act to stabilize. Can I do something to the machine whilst assessing? This is a very important part compared to the normal APLS scenario. Do I need to do something to the machine? Do I need to do something urgently before I ask help? Because that's time critical kind of an event. Do I need to terminate the HT or not? Can I wash back or not? Do I need to make any positioning of the child, mainly hypotension or his child is throwing seizures? Positioning the child is very important. And I need to make sure the airway is secure. That's the main vital part. So the clear communication between the team members and the team leader, and all the members should be aware of like what's happening to this child. Using structured communication tools to hand over, that's a very important part, using S-bar techniques like, I'm having a situation here, this is the situation, and this is the background of that child. These are my initial assessments, and I've done these things. Are you suggesting something else? What could I do next? So it's very important to have a clear format rather than what's the reality is. We always panic and we'll press the emergency buzzer and we'll wait. Come on, come and help. But those, millions of people they will rush to the scene and they don't know what's happening. So always, if we train this kind of simulated environments of using SBAR or RSVP kind of tools to have a communication, that's going to improve our resuscitation. So characteristics of a good resuscitation team member who could be competent in whatever things he or she is doing, and to committed and communicates openly, supportive, accountable to whatever the action we are doing, and prepared to admit when the help is needed. I don't know everything. I know something, but you know something better than me. So always prepare to admit and be creative to do something different at that particular scenario and participate in providing the feedback. An approach, so if you see, this is the main important thing, all these 4 domains, we have to incorporate the human factors. Situational awareness, as I talked from the initial picture, always aware of the situation. The patient is having continuing harm if I continue to do that dialysis, or do I need to stop it, or what am I going to do? And that decision making comes with experience and training. And we are dealing as a team, and who is our team leader? If there is a consultant or a registrar or whoever particular person is leading at that point, and are we adhering to that? Do we have any conflicts between our team members? And that's the task management. So it's all 4 domains need to be incorporated. That's the human factor we are focusing most. So the strategy is to improve the human factor training, the team dynamics, the influence of stress, debriefing, and conflict within the team. So always after an emergency, we debrief and get the feedback and to deal with it. So one of the important negative feedback I got from the first kind of emergency is, you're too calm in dealing with emergencies. So after dealing a decade of APLS provider kind of thing, I'm securing the airway, so I'm don't worry. So I was talking about, don't worry, Airway is secure. So one of the negative feedback I got was, you're too calm during the situation, emergency. So which is like, you need to give some cortisol to the team members. Being as a team leader, you can't be too chilled to the scenario as well. So which is, it's interesting. So this is like, if you see emergencies are like London sky. So always it could be clear by this minute, the next minute, the sky is going to get changed. Thank you very much for listening.
Prevention and management of peritonitis in children on peritoneal dialysis. My previous speaker beautifully described about the hemodialysis complication and troubleshooting. So now I'm going to talk about next 20 minutes, what is PD-related peritonitis, what is exit site infection or tunnel infection. I'd like to highlight the recent ISPT clinical practice guideline about the peritonitis management and treatment, and how peritonitis happen in a patient on peritoneal dialysis and how to diagnose it, and the management and prevention according to the current practice guideline. I have no conflict of interest to declare, but I acknowledge some case slides are collected from my friend Dr. Jean, and I'd like to request you to go through the current practice guideline and the protocol book, Pediatric Nephrology on the Go, 5th edition by Prof. Yap. So peritoneal dialysis is the utmost used RRT all over the world and continues to be an effective and safe dialysis for children with end-stage renal disease. However, according to various studies, showed that peritonitis is a serious complication that is commonly associated with PD discontinuation. And recently, 2024 clinical practice suggests that overall peritonitis rate should not be more than 0.4 episodes per patient per year, and the culture negative peritonitis should be limited less than 15% of the all peritonitis episodes. Recently, we published an article with the collaboration with India, and it got published in Peritoneal Dialysis International. And it is an online survey. We included, we got 732 responses, and there are several nephrologists and pediatric nephrologists as well responded, mostly from India, then Pakistan, Bangladesh. You can also see 5 nephrologists and pediatric nephrologists for Sri Lanka participated. And we sent them a questionnaire which contained 19 questions, and we found that what is the biggest obstacle to implement PD in this area? You can see here it is peritonitis. And also they found and encountered the common peritoneal dialysis related complication is peritonitis. And it's also correlate with the IPPN registry, where the infection is the major cause for the PD discontinuation. Now, moving to this slide, let's discuss a little bit about the pathogenesis. And peritonitis can result from bacteria reaching to the peritoneum by one of the several routes. Transluminal but touch contamination is the well-recognized contamination and risk factor for developing peritonitis. Then periluminal, that is exit site infection and tunnel infection also cause peritonitis. Sometimes gut infection and mesenteric adenitis, intestinal TB also causes peritonitis. Then hematogenous, and rarely in case of female child, it is ascending from genitourinary tract. And after entering into the peritoneum, bacteria finds the favorable environment and least host defense and actively multiplied. And the cell wall of gram-positive bacteria and the toxin from gram-negative bacteria induces the inflammatory responses, thus peritonitis ensues. And recently, this clinical practice guideline published in a peritoneal dialysis in the Prof Bradley and his group, Prof Yap Kim also here from this group. And they defined the PD-related peritonitis should be made when at least 2 of the following are present. Either effluent white blood cell count more than 100 per cubic millimeter, and among them 50% should be the neutrophil. And clinical signs symptoms like abdominal pain with or without fever, vomiting, nausea, or any other systemic manifestation, and growth of microorganism in PD effluent culture. And this slide, there is a different peritonitis definition described by the recent guideline and how we can define recurrent peritonitis. The episode that occurs within the 4 weeks of completion of therapy, prior episode, but with the different organism. If it is occurred with the same organism, that it is relapsing peritonitis. And the refractory peritonitis we defined is failure to clear the effluent cell count more than 100 microliter after 5 days of appropriate antibiotics. And catheter-related peritonitis is defined as the peritonitis association with the exist-site tunnel infection with the same organism. So now, how we treat if we suspect any case of this peritonitis. So the choice of empirical antibiotic is depend on center-specific culture, susceptibility pattern, and patient's previous history. And the antibiotic should cover both gram-positive and gram-negative coverage. And we should start monotherapy with IP cefepime. If cefepime is not available, we should consider about the first generation cephalosporin, IP cephalosporin, or in case of MRSA, we should consider about vancomycin instead of first generation IP cephalosporin. Then gram-negative coverage, we should choose ceftazidime or aminoglycoside. And what are the modification done in this recent guideline about gram-positive bacteria? So in case of methicillin-sensitive Staphylo aureus, we can give IV cefazolin, and in MRSA, IP vancomycin. And if there is a poor response, we should consider rifampin to add, but be careful about this rifampicin because in the TB prevalent area. And then Enterococcus usually susceptible to amoxicillin, so par-oral amoxicillin can be started. If it is ampicillin or amoxicillin resistant, then we can start vancomycin. And in case of vancomycin resistant Enterococcus, we should start IP daptomycin or par-oral linezolid, and duration will be all 2 weeks, 2 to 3 weeks. And Streptococcus, if it is cefazolin susceptible, IP cefazolin. And coagulous negative staphylococci should be treated with according to culture sensitivity test. It can be as IP cefazolin or vancomycin as well. Now talking to gram-negative enterobacteriaceae, so E. coli, Klebsiella proteus. So if any gram-negative bacteria showed the resistant to third-generation cephalosporin, it might be, and it is a possibility of the extended spectrum beta-lactamase producing Enterobacterialis. So it should be treated with IV or IP meropenem, or IP or oral ciprofloxacin, and duration is 2 weeks. And MPC, beta-lactamase producing organism like Enterobacter cloaca, Klebsiella citrobacter, we can start IP cefepime. If cefepime resistant, then we can give IP or IV meropenem or IP or par-oral ciprofloxacin for 2 weeks. The carbapenem resistant Enterobacter is quite difficult to manage, and we should need to consult with the infectious disease expert. We can start high dose ampicillin plus and sulbactam plus IV minocycline or polymyxin B. And if there is no otherwise specified organism is found, we can try IP cefazolin and ceftazidime and for 2 weeks. And what about non-fermenting gram-negative organism? So in case of Pseudomonas, the duration will be 3 weeks, Acinetobacter 3 weeks, and Stenotrophomonas maltophilia, it's 3 weeks. It's also like tongue twister. So Pseudomonas aeruginosa, we should start IP ceftazidime or cefepime, and or meropenem or oral ciprofloxacin. In case of Acinetobacter, if cefepime, ceftazidime or meropenem, but carbapenem resistant cases, we should add IP amikacin or IP colistin with high dose ampicillin and sulbactam. In case of Stenotrophomonas, we should start cotrimoxazole plus either par-oral or IV levofloxacin or tigecycline. So what if the culture showed no growth? What we'll do? So negative culture on day 3, if clinical improvement, we should discontinue the IP vancomycin or cefepime and switch to IP cefazolin for 2 weeks. If clinical improvement is not occurs, and we should repeat culture including fungal and mycobacterial cultures. And if culture positive, we should start antibiotic according to culture sensitivity. If it is still negative on day 5, we should, if no clinical improvement, we should consider catheter removal and antibiotic for 2 weeks after the removal of catheter. In case of clinical improvement, we should continue for another 2 weeks. Though fungal peritonitis is rare, but its consequence is devastating. So fungal isolated, if any fungus is isolated in your culture, so we need to remove catheter as early as possible. And if we found candida, so we can start oral fluconazole. And in case of fluconazole resistant, you can try echinocardin or amphotericin B or voriconazole. In case of aspergillosis, rather than fluconazole, we should start oral voriconazole. And lest the mold, if it is resistant, then we should consider about IV amphotericin B. So now, how we define exit site infection. Exit site score more than 2 or in the presence of pathogenic organism, or exit site score more equal to or more than 4 without any culture result, and any purulent discharge from the exit site with or without erythema, or acute severe erythema with or without any discharge. And what is tunnel infection? So any exit score more than or equal to 6, or erythema, edema, induration or tenderness along the subcutaneous portion of the catheter with or without purulent discharge. So how we can calculate this exit site score? So there is the grading 0, 1, 2, and you can see the indicators: swelling, crust, erythema, pain on pressure, and discharge. So can you help, could you please help me that the answer this picture, which picture below exit site score is 4 or more than 4? Picture A, picture B, or picture C? So let's highlight this picture A. There is a serous discharge, no swelling, no redness, no tenderness. So total score 2. The picture B, you can see here the crust is almost large crust, swelling, redness, and also tenderness. And in picture C, there is a swelling little bit, and there is no discharge. Crust is almost less than 0.5 centimeter, and no tenderness. So it's ultimately the picture B is score more than 4, so it is exit site infection. So what we will do if we suspect any exit site infection, we need to send swab culture and gum staining as early as possible, and also tunnel examination with or without ultrasonography. If there is associated with peritonitis with same organism or concomitant peritonitis with tunnel infection, then we need to remove catheter. If isolated exit site infection or tunnel infection, we should start empirical antibiotic, and after getting the culture sensitivity report, we can modify the antibiotic, and in case of pseudomonas, we should continue antibiotic for 3 weeks. In case of non-pseudomonal, we should continue at least 2 weeks. And if refractory, we should change the catheter, simultaneously change and replace catheter, and salvage also done. Now the main part is prevention, how we could prevent this peritonitis, because it's if one peritonitis episode, it can lead to another peritonitis, ultimately peritoneal failure, and patient need to go to the another modality of treatment. And this scope trial, this trial actually look for the risk factors for developing peritonitis, and this multivariate analysis showed that the dressing change before 7 days post-operative period is one of the risk factors, and also the early use of peritoneal catheter is another risk factor. And recent CBG guidelines recommend the catheter should be double cuffed, and the placement should be downward and lateral exit site orientation. So deep cuff is anchored within the rectus sheath, and subcutaneous cuff is in the subcutaneous superficial cuff. It is the 2 to 4 centimeter distance from the exit site, and these two cuff actually believed to reduce the infection by act as a barrier, and also keep the catheter in position so there is no peritoneal leakage. And technique used based on the patient suitability and expertise of the operator, like it could be open laparotomy or laparoscopy procedure, and sometimes percutaneous procedure also done. And perioperative intravenous antibiotic should be given prior to insertion of PD catheter. So exit site care should be postponed for at least 7 days after the inserting of catheter, unless the dressing is soiled, loose, or damp. And chronic exit site care should be conducted 2 to 3 times per week. Not more than this, unless otherwise there is a vigorous exercise or soiling of the dressing. And topical antibiotics should be applied whenever we are giving chronic exercise care. To prevent peritonitis, currently recommended the flush before fill, also recommended to wash out the organism relocated in the catheter. And nowadays, the enteral tube feeding has become the standard of care children of chronic kidney disease. And IPPN database suggests that catheter loss and high risk of infection is associated with the gastrostomy tube placement. Whereas the SCOPE trial little bit differ with that. It is not the gastrostomy tube, it is the timing of the technique and placement of the gastrostomy tube determining the risk of peritonitis. And any gastrostomy tube can be placed either by open surgical or laparoscopically. And then prophylactic antibiotic as well as antifungal therapy to children on PD in association of gastrostomy placement should be given. But what about adjunctive prophylactic antibiotic therapy? So recent guidelines add that prophylactic nystatin or fluconazole therapy for children on PD receiving intraperitoneal or systemic antibiotic therapy. And prophylactic antibiotics should be given pediatric PD patients who are undergoing the invasive procedures except the dental procedure. And prophylactic antibiotics should also be given if it is the weight contamination of the PD system to prevent the future peritonitis. This prevention is achieved fully by the proper training. PD training should be performed using a formalized teaching program with a clear content and clear objectives with consideration of the previous published ISPD syllabus. And we should, a patient should be visited as monthly basis, and we should do exercise scoring by renal nurses. And also we should take care of and check the hand hygiene, exercise, and aspect of reviewed is frequently reviewed this, because the hand hygiene is mostly the single most factor that causes peritonitis in home dialysis. And every 6 months, demo test and concept should be taken, and retraining after any peritonitis happen. Then we should train again the caregiver as well as the patient. And prophylactic antibiotic with touch contamination should be given. And this is the patient and caregiver training bundle. So training performed by renal nurse, and the ratio to the training to the patient with the renal nurse is 1:1. It's not like 2 or 3 caregiver trained by one nurse. And appropriate teaching aids should be provided. A specific protocol for hand hygiene, and also post-training concept test and demo test, and also home visit. We have to ensure that patient is doing their CAPD or CCPD by their own by safe method. And when should we remove catheter? So catheter can be removed if there is a refractory bacterial peritonitis, if there is a fungal peritonitis, if there is a peritonitis exercise or tunnel infection associated with the same bacterial causing peritonitis. And simultaneous removal and replacement should be, PD should be considered in case of relapsing bacterial peritonitis. And also simultaneous removal and replacement of the PD catheter should be done in case of refractory exercise and tunnel infection. So there is another question for you. So simultaneous removal and reinsertion of PD catheter is not recommended from the audience. Anyone can help me? Which one is correct? Relapsing peritonitis, refractory tunnel infection, is refractory peritonitis. So now let's discuss a case scenario. I'll it will take just 30 seconds. So this 12-month-old male with end-stage renal disease, background history of cystic dysplastic kidney, and previously had a catheter on his 8th month of age, and gastrostomy was performed 2 weeks before this elective surgery. Electively, gastrostomy tube is given, and when the catheter is block found, the X-ray is done, And the question is, what are the issue with this catheter placement? The exit site within the diaper area, you can see, is it diaper area? Tip of the catheter is flicked out of the pelvis. Exit site is not in the midline, and catheter has lateral orientation on the exit site, which is the main cause of the catheter block. Any cases? So it's a tip of the catheter is flicked out from the pelvis so that it's blocked. So in a nutshell, infection-related complications remain the most significant cause of morbidity in children with peritoneal dialysis. Early identification of exit site infection and tunnel infection and peritonitis is crucial for continuing PD. Prophylactic nystatin or fluconazole therapy for children on PD receiving IP or IV antibiotic. PD training should be performed using a formal and a structured training protocol, and enhanced uniformity of PD practice based on quality improvement principle has resulted in a decreased frequency of peritonitis.
Grateful to the Sri Lanka Society of Nephrology and Dr. Vindhya for giving me this opportunity. As a bit of context, I work in St. John's Medical College in Bangalore, which is in South India. And we are the oldest and largest standalone chronic dialysis centers for children. We have a lot of experience with doing both acute and chronic dialysis. And yet, we are just taking baby steps in providing supportive care. So supportive care, another word for it is palliative care. And I'm grateful that I've got this opportunity to speak about this. I have interacted with and been inspired by a couple of people whose help I have taken in discussing these issues and beginning our own palliative care program for children. I'm going to talk about chronic dialysis, but these principles would apply to children on acute dialysis as well. So we'll talk a little bit about supportive care, which is otherwise known as palliative care. We'll talk about how children with advanced kidney disease suffer, what the goals of supportive care should be, and how to go about providing supportive care for children on dialysis by us. I'm assuming we are all, none of us is probably a trained palliative care specialist. So we all know these comorbidities of advanced chronic kidney disease in children related to uremia. They have hypertension, anemia, poor growth, mineral bone disease, electrolyte disturbances, and metabolic acidosis. Anything else that they have? Did we ask them if they have anything else to talk about? So what is pediatric supportive care? Pediatric palliative or supportive care is a needs-based approach to care focused on providing relief from the stress and the symptoms of a serious illness. And its goal is to improve the quality of life for the child as well as their family. So both the World Health Organization and the AAP endorse supportive care. They recommend that we integrate supportive care for children with any life-limiting or life-threatening illness, and we all know that CKD and kidney failure is definitely life-limiting. And it's also recommended to continue supportive care regardless of whether treatment is actively going on or not. So who is this meant for? It's meant for children living with a serious illness, as we discussed, to provide relief from symptoms, to improve their quality of life. And I think what's most important, which I certainly misunderstood initially, is that supportive care should be given at any stage of the disease. It is not end-of-life care only, and can certainly be provided with concurrently with curative treatment. So what does it include? It includes addressing physical symptoms. It also includes addressing psychosocial distress and providing good, high-quality communication about the patient's illness with the patient as well as their family. So there are guidelines targeted at adults for conservative kidney management and kidney supportive care. And the adult nephrology world is different. There are many elderly patients who choose to forego dialysis when they've been diagnosed with kidney failure. And so kidney conservative care is meant for those who would prefer end of life without dialysis, at the same time managing all morbidities of CKD, avoiding dialysis and their symptoms as well. So this nice guideline basically mentions that supportive care can be provided at any and all stages of kidney failure management. So what are the challenges of incorporating supportive care? Have you ever called or thought about palliative care for your patients? It's our misconception that it's end-of-life care only. We also think that if we mention the words palliative care, we have given up on the patient, and we are scared that the parents will think that we have given up on the patient as well. There are also some real challenges. Who is trained in providing palliative care to children on dialysis? Very few. The palliative care specialists are not familiar with children with kidney failure, and we are not trained to provide palliative care to our patients as pediatric nephrologists. We are unaware of what symptoms the children may have other than our usual list of comorbidities, and so we don't ask about them. And there's a shortage of manpower. We really don't, with our large group of patients, we may not have time to spend and inquire about all the symptoms that the children may have. So this is a picture of how CKD, and I'm sure it may present similarly here. It is different than how it presents in high-income countries. Late diagnosis is common. And so the challenges of managing pediatric CKD in high and low middle-income countries are that the diagnosis is often delayed in low middle-income countries with more severe comorbidities. There are few centers that provide pediatric dialysis and transplant. Dialysis is not paid for by the government in all countries, and therefore patients have to pay out of pocket. And in our study, we had 40% of patients discontinue treatment and had high mortality rates despite having a pediatric dialysis center in the geographic vicinity. Transplant in our dialysis patients is frequently delayed. There's deceased donor transplantation is inaccessible to many patients in low resource settings. And certainly in our state, children are not prioritized on the transplant wait list. So we have patients with 6, 7, 8 years of dialysis. So this is a study when we interviewed parents of children who had been diagnosed with kidney failure. And if you look at the quotes, which I'll go through briefly, the caregivers also need our attention. There's a lot of fear, especially when the diagnosis is late. There's anxiety, and they're under a lot of stress. This is the study where we looked at the health-related quality of life in children with pediatric CKD. And I think in our setting, or where treatment is not free, the biggest burden that we identified was financial burden. How were they going to pay for treatments? The second was a parent who's doing dialysis suffers a lot of psychological distress and social isolation, and so does the child. There's a lot of social stigma attached with the diagnosis of kidney failure, and a child who needs dialysis is viewed as someone who has some sort of transferable or transmittable disease. And so looking at these three domains, we realize that caregivers need supportive care as well. CKD is burdensome to the child as well. As we've discussed, they have a lot of symptoms and also a lower survival rate. There's significant impact on parents and siblings. Children may have chronic pain, sleep disturbances, and other symptoms. So while we know the traditional comorbidities, what symptoms we often don't ask for, at least I haven't, but I'm learning to, is whether they have pain. And it's not pain on the day of the clinic appointment. It's pain in the last week, pain in the last month, because children are very literal. Have they been having sleep disturbances? Our children on HD develop a very weird, dysfunctional relationship with food because they're obsessed about interdialytic weight gain. Their sadness, loneliness, and whether they have anxiety or depression symptoms needs to be screened for. We also need to do more research in this area. There are some studies that have shown that the health-related quality of life and patient-reported outcomes are important to patients with CKD. The concept of life participation, which is an ability for a person, certainly a child, to live meaningfully, is very important and is more important to patients and parents than it is to clinicians. This is a study where we looked at the quality of life in our dialysis patients. And the blue bar is normal children. The yellow bar is the CKID data from the United States. And as you can see, the red bars, our scores were all much lower. And we found that the physical domain was the most effective. So the worst quality of life was associated with the child's inability to attend school, anemia, and the longer duration of their illness. And these are aspects to address when we introduce supportive care. So what do children say about life participation? This is a study done by my medical student where we actually interviewed the children and we asked them to identify pictures that they believe portrays things that they think about. So the first one is of school, and we find that children, our patients on chronic dialysis, drop out of school. And it's often because the parents pull them out of school. So they miss school, they miss the lack of, they miss playing with their friends. The school environment and community is often hostile to them. They are viewed as somebody who probably can't be integrated into normal life. And this is probably different compared to other countries. And this is just a picture of a child who dreamt of seeing the beach. He also wanted a kidney transplant. So I think asking children what they think and what they want is really important. So what do adolescents want? The clinicians, caregivers, and the adolescents all want to grow, to live, to survive. The adolescents also want to be physically active and participate in life. This is a screening tool. There are not many. I think this may be the only one that screens for palliative care needs for children on dialysis. Families also are not familiar with palliative care, and so if we don't bring it up, they are not going to ask about it, but they are not opposed to it. Families had a positive, they were interested in exploring supportive care options for their children and did not view it negatively. So who should provide supportive care for children on dialysis? Is it the palliative care specialists? Is it us, nephrologists? Is it allied health team members, which we may or may not have access to, nurses, social workers, psychologists? We ourselves have barriers to sending our patients to specialist palliative care for the reasons that I mentioned. We also believe that we don't want to burden patients and families with another visit and introduce them to another healthcare team. In the end, in this survey, we believed, nephrologists, that there may not be added value in adding a pediatric palliative care service. So as a result, supportive care measures are inadequate in patients, pediatric nephrology patients. So we all have a responsibility to provide palliative care, whether we are pediatricians, pediatric nephrologists, or specialists palliative care. As pediatric nephrologists, we can handle basic symptom management if we ask, or we can refer patients for those who have symptoms that we feel we are not trained enough to prescribe for. We can handle the depression and anxiety to screen for it and ensure that they get counseling services. And it is very important that we as pediatric nephrologists focus on communicating well with families, asking them about their goals and challenges when undergoing treatment. The specialty palliative care people do manage, they're the experts in managing refractory symptoms, managing depression, anxiety, and also addressing the more complex, serious illness communication. So they're them and we're us. And I think we may be required to take on some specialty palliative care responsibilities, but we do need training to do so. This is a conceptual model of how palliative care or supportive care may be integrated into nephrology. And so these waves that you see are the higher needs and the times when supportive care measures should be introduced or be prioritized. So as you can see, it comes at the diagnosis, it comes at the start of dialysis, at the time of transplant referral, and then at other times the supportive care needs may be stable or not so much. Flourishing is a term for children and their families to live well. The purpose of our caring for children with advanced kidney disease is to promote flourishing. And so if we can use supportive care or palliative care as a means to promote flourishing in the child, that would be ideal. How do we promote it? By addressing the goals, hopes, values, and perspectives that are unique to each family. We need to inquire about, to understand, and integrate patient and family goals, hopes, and perspectives into the decision-making that we take medically. And this is where collaborative decision-making is so important. Sitting down with the family and the patient to discuss jointly goals of care and treatment options. We recently conducted this webinar by the joint ISN and IPNA webinar, where we wanted to discuss how to bring supportive care to a global audience. It is relatively better established in high-income countries, but the burden is much higher in low and middle-income countries. And hopefully, with more such webinars, we hope to begin introducing kidney supportive care at every stage of CKD management for children. So, how do we serve as a bridge between pediatric nephrology's primary palliative care and specialty palliative care? We could use resources and learn about it. We also need to be trained more. This is an area that is really insufficiently utilized to improve patients' lives. There are some resources there that I can share if required, if it's not visible. And so, what can we do? We can address symptom management. We can also screen for depression, anxiety, and identify psychosocial issues in our families. And if required, funnel them into specialty palliative care. So before I conclude, I'd like to acknowledge the following people who I've begun to work with. We have started screening our patients for CKD symptoms and integrating a palliative care team member into our chronic kidney disease and transplant clinics, as well as in the hemodialysis unit. I hope it goes well. We're just beginning. So in summary, supportive care for children on dialysis is much needed. The goal is to improve the quality of life by addressing physical symptoms, emotional distress, creating goal-based care, ensuring an improvement in life participation to enable flourishing. We as pediatric nephrologists can begin basic primary palliative care, but we have to remember that we will probably need to adapt to our own local needs and limitations.